everybody. January 1st, 2025, Wednesday, 3:30 p.m. Pacific Time. Happy New Year. And thank you for my mother for getting me this Christmas gift. It's a wonderful fleece. So we are going through this issue of JAVMA, February 15, 2017. We are talking about this paper, Colonoscopic and Histologic Features of Rectal Masses in Dogs, 82 cases from 1995 to 2012. This comes out of multiple vet schools as well as specialty hospitals and VDX, Veterinary Diagnostics. The objective: to evaluate colonoscopic and histologic features of rectal masses in dogs, retrospective 82 dogs. Results showed that multiple rectal masses were observed during colonoscopy in 6 of the 82 dogs, but no lesions were visualized or add to the colorectal junction. Epithelial neoplasia accounted for 58 of the 64 dogs, of which 71% were benign adenoma or polyp, and 29% were adenocarcinoma in situ or adenocarcinoma. Complications of colonoscopy occurred in 3 of 82 dogs, but considered minor. A discrepancy in diagnosis occurred in 5 of 16 dogs, of which both the scoping and surgical biopsy samples were available for histologic review. Conclusions were that the results suggest that multiple rectal masses are uncommon and secondary lesions or rad to the colorectal junction were not found. All right, let's go to introduction. And right off the bat, I'll say that that conclusion is kind of weak because they found actually lots of different conclusions in this paper, and I don't know why they didn't mention it in that summary paragraph. Introduction: the prevalence of gastrointestinal neoplasia is relatively low in dogs. It makes up 3 to 10% of all tumors. Up to 60% of GI tumors affect large intestine. 50 to 60% of those are malignant. Adenocarcinoma most common. Other less frequently reported: lymphoma, leiomyosarcoma, hemangiosarcoma, plasmacytoma. Adenomatous polyps account for most benign tumors, but leiomyoma and fibroma are also possible. Carcinoma in situ exhibits histological atypia, which can progress to invasive malignancy in 17 to 50% of dogs. A complete scoping extending from the acutaneous junction to the ileocecocolic valve is recommended. You have to evacuate the entire colon, which is time-consuming and potentially complicated procedure that adds expense. It requires withholding food from the patient for 24 to 36 hours and then giving oral administration of polyethylene glycol solution or bisacodyl tablets and multiple enemas. The oral administration of osmotic preparations is not benign, has been associated with vomiting and aspiration pneumonia. A recent study found that 8.5% of dogs undergoing flexible colonoscopy complications in 8.5% of dogs undergoing flexible colonoscopy, although most of the complications were minor and death only occurred in 0.28%. Materials and methods. Lesions of epithelial origin were classified as hyperplasia, benign polyp or adenoma, carcinoma in situ or adenocarcinoma. The American Joint Committee on Cancer tumor grade was assessed as follows: T0, no malignancy; TIS is carcinoma in situ; T1 is invasion of submucosa; T2 is invasion of muscularis; T3 is invasion through muscularis to serosa; and T4 is invasion of other tissues. Results: mean age 99 months old. Which, why put it in months? I mean, nobody does that with dogs. It's, after 12 months, start going with years. Mean body weight was 26.2 kilograms or 57.6 pounds. Most of them were either castrated males or spayed females. 16 were mixed breed dogs, which made up the majority. Clinical and laboratory findings: 96.3% of dogs had at least one clinical sign. Hematochezia was 92.7%. Tenesmus 57.3%. Dyschezia 22%. And mucus in the stool was 15.9%. In those dogs with clinical signs, the median duration of those signs was 5 months. Digital rectal examination found a mass in 86.6% of dogs. In 3.7% of dogs, the colon was described as having irregular mucosa, and 9.8% no abnormalities. 69% with digital palpation of rectal mass. Median estimated maximal diameter of the mass was 2.5 centimeters. Diagnostic and imaging findings include thoracic radiographs showing no metastatic disease in 97% of dogs. 23% had abdominal radiographs but did not reveal any abnormalities. 70.7% had abdominal ultrasound, which found sublumbar lymphadenopathy in 27.6%, colonic wall thickening in 15.5%, and a colorectal mass in the region of the colorectal junction, 15.5%. Colonoscopy findings and complications. Bowel preparation consisted of the use of osmotic bowel cleansing solution in 57.3%, and at least one enema in 64.6%. Polyethylene glycol-based agents were used in 18 of the 47 dogs, whereas sodium phosphate monohydrate-based products were used in 29 of 47 dogs. Complications from colonoscopy or bowel preparation, 3.7%. One patient had self-limiting dyspnea, another one had diarrhea, another one had increased respiratory rate with fever and arrhythmia. A single rectal mass was found in 92.7%, multiple was 7.3%. Locations: distal rectum in 31 of the 64, mid-rectum in 18 dogs, proximal rectum in 5 dogs, and at the colorectal junction, 10 dogs. In all 6 dogs with multiple masses, all masses were judged to be located ab or rad to the colorectal junction with no lesions present entirely within the ascending, transverse, or descending colon. Colonoscopic mean estimated maximal diameter was 2.1 centimeters for these masses. So that's pretty close to what they palpate on digital rectal palpation. Masses were emanating from ventral aspect of the rectum in 21 dogs, dorsal aspect 18 dogs, left side 8, right side 6. Lesion type, with 10 of the 20 lesions were described as cauliflower-like or sessile. 5 were pedunculated, 4 annular, 1 diffuse. Neither histologic diagnosis nor tumor grade was found to be significantly associated with the colonoscopic estimate of lesion size, presence of multiple lesions, circumferential lesion location, or ORAD, ab-ORAD lesion location. Histologic diagnosis, so adenocarcinoma versus polyp, which is adenoma, was significantly associated with lesion type, with annular or diffuse being more likely to be classified as adenocarcinoma. Furthermore, there was a significant association between lesion type and tumor grade, with annular and diffuse being more likely to be higher grade, compared with pedunculated or cauliflower and sessile lesions. Those are important findings that should have been in the conclusion, I think. Surgical procedures: mucosal eversion, which, by the way, is in the picture there down below. That's mucosal eversion / rectal pull-through technique, for those who've never seen it before. Mucosal eversion was performed in 33 of 68 dogs, rectal pull-through 25 dogs, ciliotomy 7, dorsal perineal approach, pelvic split, endoscopic debulking with a snare, 1 of each. In the remaining 14 dogs, either surgical resection was not performed or details were not discussed in the medical record. Histologic review: of the 24 dogs which had histologic slides or blocks from colonoscopy, biopsy samples, epithelial proliferation was seen in 17 animals, so benign polyp or adenoma in 13, adenocarcinoma or in situ in 4, with a diagnosis of colitis in 4, diagnosis of lymphoma in 2, diagnosis of mucosal hyperplasia in 1. 13 of the 17 epithelial tumors were classified as well differentiated, 2 were intermediate, 1 was poorly, and 1 was anaplastic. For the 64 dogs for which histologic blocks of samples obtained during surgical resection were present, epithelial proliferation were in 58, meaning polyp or adenoma, in 41 of them, and adenocarcinoma or in situ in 17. A diagnosis of plasmacytoma in 3 dogs, lymphoma, mucosal hyperplasia, and leiomyoma, 1 of each. Of the 17 dogs in which adenocarcinoma or in situ was diagnosed, the tumor grade was TIS in 8, T1 in 3, T2 in 5, T3 in 1. 34 of the 58 lesions of epithelial origin were classified as well differentiated, and 21 were classified as intermediate, 3 poor, none were anaplastic. Discussion: multiple rectal tumor masses are uncommon. Secondary lesions ORAD to the colorectal junction were not found. For several patients, biopsy samples obtained via scoping were classified as more differentiated than were samples from surgery, potentially underdiagnosing malignancy. That's a big point to make. Complication rate from scoping was only 3.7%. In a larger study, 8.5%. aspiration of polyethylene glycol-based solution, colonic perforation, and bleeding after biopsy were reported complications. Additional hospitalization and cost incurred for some of the bowel cleansing protocols, the requirement for general anesthesia, the added technician time for assisting with the procedure and cleaning the scoping equipment all add to the expense. Colonoscopies were performed on a different day from surgery in 43.1%, which is good because it prevents liquid colonic contents from contaminating surgery site. But when you stagger scoping and surgical procedures, you accumulate additional duration of hospitalization, anesthesia, and cost to the owner. In human patients, the diagnosis of adenomatous polyps has historically been based on scoping appearance, with pedunculated, sessile, and depressed lesions having differing prognoses. And by the way, in terms of their increased cost to the owner, who cares? If your goal is to provide the best recommendation for that pet, the finances are up to the owner to decide. But ignoring that, because as a doctor you should be ignoring that when you're trying to figure out what the best plan is for your patient, you ought to offer them the best. And if staging, the scoping, and surgery is best, even though it costs more anesthesia, whatever, let owners have that option, Results of the present study may suggest that colonoscopic findings correlate somewhat with histologic diagnosis and tumor grade. Previous studies in dogs have also suggested a relationship between prognosis and lesion appearance, with one study suggesting patients with single pedunculated lesions had longer survival compared with cobblestone-like or annular. Another study noted that dogs with multiple or diffuse lesions had higher recurrence rates compared to dogs that had single masses. Rectal pull-through are associated with higher morbidity rates, whereas others reported mucosal eversion associated with good outcomes and few complications. Two studies of dogs with colorectal epithelial tumors reported 12% to 19% of dogs had multiple colorectal masses. However, in the present study and another study of 33 dogs with colorectal carcinoma that underwent proctoscopy, no patients had multiple lesions or rad to the colorectal junction. We suggest that complete bowel preparation followed by scoping extending to the ileocecocolic junction is a relatively low-yield endeavor, provided that a thorough scoping examination of the complete length of rectum and colorectal junction is performed to evaluate multiplicity of masses in that region. A more localized intraluminal evaluation with proctoscopy or transanal single-port evaluation may be a more appropriate diagnostics tool for selected cases. Proctoscopy or sigmoidoscopy has been performed for many years and can provide visualization of the rectum and a portion of descending colon. Proctoscopy is not usually performed with insufflation, and therefore visualization of rectal mucosa may not be as clear. Transanal single-port evaluation using laparoscopic single-port device to evaluate the rectum with a rigid scope after insufflation of the rectum has been reported. This has been used in people in association with transanal microsurgical techniques for lesion resection, and have been used this in place. They have used this in place of colonoscopy for evaluation of the rectum in some dogs in this study. Non-endoscopic techniques such as CAT scan, pneumocolonography have also been investigated in dogs, may provide so-called virtual colonoscopic platform. Although performance of this technique requires a standard bowel preparation similar to that for scoping, the CT pneumocolonography technique has the advantage of additionally providing valuable staging information for lymph nodes, looking for spread of disease. There's a disagreement of 30% found in one study and was mainly attributed to the superficial nature of scoping biopsy samples and the inability to harvest associated submucosa or deeper tissue necessary to evaluate tumor invasion beyond the mucosa. So that disagreed. Scoping and surgical biopsy disagreed in 30% of cases in that study. That's high. It's a third of cases. In 4 of 12 dogs in the present study, in which extent of tumor differentiation was determined for both colonoscopic and surgical biopsy samples, less differentiation was seen in surgical biopsy, suggesting that colonoscopic biopsy may underestimate the extent of differentiation of rectal tumor in dogs. This observation has been reported previously in dogs. We suggest that biopsy samples collected with larger biopsy forceps or by means of wedge incision might lead a higher sensitivity. Advanced imaging such as transrectal ultrasonography, CT, virtual colonoscopy, and MRI may have higher sensitivity evaluating tumor invasiveness, and each has advantages and disadvantages in human patients. And that's the study. My other two concerns is that you want to have a higher number of cases, and also this trend of veterinary medicine where we don't have complete medical records for these cases. You know what? Then they shouldn't be included in the study. If you're going to have a good paper, a good quality paper, and you're going to accept cases that are not complete, then don't put them in the study, and either get more institutions to gather information that are more thorough, or wait until you have more cases under your belt, with a strict criteria for what you're expecting to collect from those cases. So those are my two criticisms of the paper. Otherwise, useful information there. Please subscribe, hit like, share, donate, and I'll see you guys again tomorrow. Take care.